Good evening, everybody. Tonight is Glenn Grossman's webinar about the latest in the COVID virus. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs in the US and outside of the US. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. I'm taking over for Rebecca just for tonight. Hopefully she'll be back next week. Okay, thank you, Glenn. Thank you very much, all of you, for joining us. And thank you very much, Glenn.
Thank you very much for moderating tonight.
My pleasure. Okay, you tell me when you want me to start with the questions, and I'll be happy to do that.
Sure. So usually we start just reviewing the week in review in the US and abroad. You want me to go ahead and start with that?
Yes, please.
Okay. So I will share my screen. All right. So we were decreasing for a while in the number of cases around the United States. This is the United States as a whole, but we're sort of, over the last week, we've had definitely a flattening out. So we're no longer decreasing at the same rate that we were previously, which is unfortunate. Because as I've mentioned earlier, this will be our new floor. So as we enter the fall and winter season, a lot of us are expecting another another surge. So I guess this would be the third surge, what would have been the second wave. But we never really finished the first wave. So we've had surges. So we're considering the first surge. Now we're finishing up the second surge, which is still, a lot of people are still getting sick. This is the number of new daily cases. These are diagnosed cases is still over around 40,000 per day. And that's average. So it's not under control. It's still out of control around the United States. Some places are better than others, which we'll look at in a second, but it's a flattening. At this high level, so still roughly over 40,000 per day. And so this will be the new floor. So as we enter the fall and winter, then if we have another surge after at that point, so say September, October, November, then the same way that the floor for the second surge started where the first surge never finished and got down to zero, the second surge now will start, or the third surge will start from whatever this new floor is. So hopefully it will not get too bad, but we are starting from a higher floor, unfortunately. You can see that the number of people hospitalized has gone down. This is for a few reasons. One, the people who have been infected in the second surge it's been summer. People have tended to be a little bit younger, outdoors, more interacting with other people. The other thing is that we've learned a lot since the first surge. And so we have more effective medicines. And so people not only are cured and survive, but among those who survive, they tend to leave the hospital much quicker. The length of stay in the hospitals has gone down a lot as well. So that's great. And so what this means is that when you add up the total number of people hospitalized at any one point, there's less people over the same length of time, simply because of the decrease in time per person. And the daily deaths, you can see this is great news. We weren't sure how many deaths that there would be. My best estimate is that there are approximately 250,000 people that have died from COVID-19 or associated with COVID-19 since the beginning of March. And hopefully we'll get into that a little bit later today. But this is where we are. Let me just go to some websites. All right, so what we're looking at here is one of the dashboards that we looked at previously, and you see that there's a lot less red than we've had in previous weeks, which is great news. The other one that we tend to look at is this one. This one still has a lot of red. This one is this is COVID exit strategy. This one uses the federal government's criteria for reopening. And so if you recall back in, what is this, March or April, the original White House criteria for how we reopen were based on symptoms and cases, hospitalization, and on testing. And when you use just these three criteria, then that's where you get these a lot of red still in the country, and the dark red. The Northeast tends to be doing pretty well. And then if we look here, I like this website. When you look here at regional daily tests, so you can see that the testing rate has gone up a lot in the Northeast, and the percent positive rate has stayed small. The Midwest, the testing rate has also continued to go up, and the testing rate, unfortunately, the positive test rate is not going in the right direction. It's getting higher and higher. So we've seen a sharp decrease in the Northeast from their first increase. In the South, we hit a peak earlier back in July, and then it was going down, and it's gone down a fair amount since then. It's still quite high at 9.2% positive, but it's a lot less than it was at its peak, and it's still decreasing a little bit. So the reason that we're flattening is mostly because we are seeing a rise in the Midwest, unfortunately, still, and then the West, we've also seen a decrease from its peak. Let's see. In addition, so I was just showing deaths. The number of deaths have gone down a lot this surge. And so you can see where they're mostly occurring. It's the deaths over the summer were mostly occurring in the South and in the West. So over half of them were in the South over the last week or so, with the remaining quarter in the West. And when you look globally, I like this graph. This is showing how the world has dealt with this. So green countries over here were the ones that were doing pretty well. You see a lot of smaller countries because it was easier to address the disease in a lot of the smaller countries. And so the ones that are doing well were green. The ones that are doing poorly are red, and the ones that are in between are orange. And so it's the red ones are staying roughly the same. Unfortunately, it would be better if they were going down, but right now they're roughly the same. Let's dig into them a little bit. So let's see. We can look at, let's jump into some of the bigger ones. One of the things that I've pointed out in previous weeks is that in the Southern Hemisphere, it is currently winter time, and they're just finishing their winter. And so when we look, I prefer to look at it over here. So when we look at the original surges, so if we look down at the beginning, the European Union got hit really hard, and the United States got hit really hard back in this time frame. But then since then, the European Union really went down a lot, whereas the United States had this massive second surge that the European Union did not have, which is unexpected. I mean, it was based because we never got our floor down. It was expected that we'd have another surge, but it didn't need to be that way. South America, you see, did not have that original surge because when the global outbreak first happened and they shut down immediately, it was wintertime, or rather it was summertime there. And so the spread slows down a lot just because of summer conditions. People spend more time outside, and the weather is different, and so it slows the spread. But now wintertime, you see that South America has just climbed. It's just continued climbing throughout their entire winter. And so we've been looking to South America because a lot of us predict that will be our future, because this is a real life case study of what seasonality will do and what the increase that we expect to see based on winter. I also put on here South Africa. South Africa, you see, had a much sharper jump it's winter time there. They're finishing their winter there. And so you see that they also had a delay early on. And then it wasn't until they started hitting their winter time that they really started to get that sharp peak again. So with the United States, that's a lot of us are expecting that it's going to as we approach winter to a normal flu season, that it's going to start to pick up again at that point. Australia, also southern hemisphere, you see that they had a very small peak originally. All of these regions are normalized. So that means that they're reported per million people. So it's comparing apples to apples across all the areas. The United States, for instance, is a very large country compared to some others, roughly the same size as the European Union, but it's apples to apples because we're comparing everything per million people. But Australia, you see, had a small peak at the beginning when the rest of the world did, when Europe and US were hit. But then again, it was summertime there for them. So they were able to bring it down, especially they had really good policies and testing and stuff. And then it's winter time now, and you see that they weren't able to keep it completely down to zero. So they did have another spike that came up as a second wave. That these you can call more like waves because they did have a peak and then went down to near zero. You see that Africa, surprisingly, a lot of us back in March and April were expecting that Africa was going to get hit really hard. And Africa managed to not get hit as hard as a lot of us were thinking. We still don't know why. There's a bunch of hypotheses that are still being investigated, but this is really good news because it could have gone really differently there. Asia too. So China has been extraordinarily great at keeping the virus down. And so because China is so huge relative to the other countries in Asia, it's one of the reasons that Asia is staying so small. But a lot of Asia has also done really well with their policies. They had the bad experience with the swine flu and SARS-CoV-1 and other viruses there, and so they were on top of things. They had really good policies. So when you normalize Asia per million people and compare it to the United States per million people, you can see we don't have our act together in the United States. We really need to improve our approach to epidemics and pandemics. All right, I think that's it for now. Well, I'll get back into some of these other things in a little while. Test and trace, this is just another one that I sometimes look at. And the states in blue are doing great. We're testing enough and we're tracing the positive test results. So this is really good news. There's still a lot of states that are not sufficiently testing or tracing. And so these states continue to be at high risk for continuing spread, especially as we go into the winter season. They really need to get their act in order. All right, I will send it back to you.
Okay, so the first question is, last week, the U.S. executive branch tweeted that only 9,100 people have actually died from COVID-19 in the U.S. since March. Have only 9,100 people actually died from COVID-19 in the U.S.?
Yeah, so this was a big thing that exploded on social media around a week ago. And so I can show this to you. It's really interesting. So basically, the CDC on this website over here, so the CDC has weekly updates on COVID-19. They provide a lot of different kinds of data for public health scientists, for epidemiologists, and also for the lay public. They provide information to. They have multiple audiences that they're addressing. And one of the things that they've submitted are the comorbidities that are listed on the death certificates among people who die. And these are comorbidities, sort of, but they're not necessarily things that preceded the COVID-19. Like, so it's not necessarily diabetes or other conditions that preceded the COVID-19. It could be people who had COVID-19, then that triggered a heart attack in them, and then on the death certificate, it says heart attack. And so it lists all the things. The problem is this thing right here, it says for 6% of deaths, COVID-19 was the only cause mentioned. And so there was a conspiracy theory that concluded because of this, that meant that of all of the reported deaths, and the number of reported deaths are over in this part of the CDC, where they report deaths over here, the number of reported deaths are 188,000 total deaths. And this is a different part of the CDC, the COVID tracker. They report as of September 6th, 188,000 deaths. And so if you put those two facts together, then the conclusion was that there were only 9,100 people that actually died. This is totally untrue. And so I think that this is a good opportunity to dig into this a little bit more and describe how we do all these calculations and where all this comes from. All right, so a few months ago, we looked at this table, this 2x2 table. In epidemiology and genetics, we sometimes call this a Punnett square. And you can also just look at it as a 2x2 table. I'm gonna jump to this one because it's a little bit cleaner. So basically on one axis is the number of reported COVID-19 deaths, and then deaths that are not reported as COVID-19. And then over on this axis are deaths that actually were due to COVID-19, and then over here is deaths that were not actually due to COVID-19. So you can see over here, this is where the 188,051 that came from the website we just looked at. So that's over here, the 188,000. All right, so if you look over here, this is the total number reported as COVID-19. That's where we get this number. But we can predict that not all of these are actually truly COVID-19 deaths. So for instance, they're in the news, there have been some cases, and this is a lot of people, our conspiracy theorists in particular, are saying, oh no, there are not so many true COVID-19 deaths, that people might be in car accidents, and on their death certificate, it might say COVID-19, but really it was the car accident that killed them. And so even if there's only a 90% accuracy rate in terms of what that is, then that means that if there's 90% accuracy, then that means that 169,000 of these 188,000 are true COVID-19 deaths, and then the rest were listed as COVID-19 deaths, but were not true. But the thing I want to make clear to everyone is that this estimate of 250,000 comes from a different source. So the 188,000 comes from this source on the website. And so the way that they do this, again, they look at all their death certificates. Any death certificate that says COVID-19 anywhere on the death certificate is listed as a COVID-19 death here. And so that's where we get that number from. This website you've seen in previous weeks, and this website lists all deaths in the United States, regardless of cause. And so it's a way of looking at epidemics to see if there's excess deaths that are going on. And in this epidemic, if you add up all of these excess deaths since March, then that's where you get roughly 250,000 excess deaths. So there are different ways of calculating it. This one, again, is anything that has COVID-19 on the death certificate, whereas this one is just all the excess dead bodies, regardless of how they died. But you know that there's no other epidemic going on right now. COVID-19 is the only reason that there would be excess deaths right now. And so as a result, we can very accurately assume that these excess deaths are COVID-19 related. And so when you combine these two things together, you have the two. So that means when you look at the actual COVID-19 deaths, then that's where we get around 250,000. But then that means that there's a lot of deaths that are not actually diagnosed as COVID-19, even though we see on the website we just were looking at that they were actually excess. And so one way of interpreting this is that if you go back to what we just said, that there is this idea on the CDC website, which is false. I'll get back to this other idea in a second. But let's say, for the sake of argument, that only 6% of these reported COVID-19 cases were actually truly COVID-19. If we put 6% in here, then that means that there was a lot of misdiagnoses, but then it must force us to conclude that there were even more false diagnoses in the other direction. So there were deaths that were not reported as COVID-19 that were actually COVID-19. And so it's a constraint. This Punnett square constrains us that it has to be the case because for both of these numbers to be true. And so this is just, we use this in every disease when we're looking at excess deaths. And so this is a really, really important tool that we have for looking at this. Let me go into this a little bit further. So here's the graph that we just saw. These are the total number of excess deaths. If you add them up, that's where you get a little bit over 250,000. We can look at this regionally. From March 1st to July 25th, there at that point we're already around 220,000 excess deaths, and you can look at how the spread appeared regionally. This was an analysis on the CDC data that the New York Times had done. But so the question is, how could all of these people be dying and not know that they have COVID-19? We hear all of these horror stories of COVID-19 where people can't breathe, it's a respiratory disease, and it's causing all these symptoms. How could people be dying and not even know that they have COVID-19? Well, there's two reasons for this. One is that it could just have been left off of the death certificate. So for instance, maybe the diagnosis wasn't given, particularly at the beginning, that first surge that we had. A lot of people might have been dying and might just not have been diagnosed, and that it never made it to the death certificate. But another reason is that a lot of this disease is asymptomatic. And so what does that mean? What does it mean for a disease to be asymptomatic? What that means is that okay, can you mute yourself for 1 sec?
Yes.
All right. Thanks. And so when a disease is asymptomatic, that means that there's still viral replication going on. It's just that there's no symptoms. But if there's still viral replication, if the virus is still infecting, destroying cells, replicating, causing havoc in the body, that doesn't mean that the person's healthy. Being asymptomatic doesn't necessarily mean healthy. And so there's other systems in a person's body that can still be ravaged even if the person has no symptoms. Here's an example. This is a study that was just published over the last week or two. So what was it? This was end of August. And so this was looking, there've been a bunch of studies looking at the replication of SARS-CoV-2 in the heart, in the cardiac tissue. And what we know is that a lot of people are now thinking about COVID-19 as a form of heart disease rather than lung disease. And so even if people don't have symptoms, there's still replication going on in the heart. The virus is still infecting a lot of people's hearts. And so they've looked at this in different ways, looking clinically within people. This study was looking at and test tubes, looking at in the lab, looking at the muscle tissue itself to see what the replication looks like. And they concluded that they used the term carnage, that it's causing carnage in the heart, that basically it is destroying the heart fibers, the long heart fibers, and breaking them apart into small pieces. And so being asymptomatic and not having any lung symptoms does not mean that the replication is not going on in the heart. And in fact, to take this even one step further, when you look, these are New York City excess deaths. How were the excess deaths recorded? So these were the ones that were not COVID-19, but were excess deaths. What you find is there were thousands of additional ischemic heart disease deaths. And so a lot of people were dying from cardiac arrest and from ischemic heart disease, so blockages in the heart that was recorded as ischemic heart disease that were likely due to COVID because this is all these excess deaths. And so they might not have had traditional respiratory symptoms. Their only symptom was that they felt like they were having a heart attack. That's what they died from. But indeed, on reflection now, looking at all these additional sums of evidence, there's a lot of people who have been infected with SARS-CoV-2 who are having heart issues as a result. And we don't know a lot about this right now. There's still a lot of information we don't know. We don't know how long this persists. We don't know what the long-term damage might be. So for instance, if someone gets infected with SARS-CoV-2 now, is this something that will stop in a month or two once they no longer have respiratory symptoms? Will it will it cause scarring? Will it cause problems for years? We don't know any of these answers yet. And so this is an open question. This is something that we're also going to be needing to think about when it comes to vaccines, because the worry we'll talk about vaccines a little bit later today, hopefully, but the worry about vaccines is that if people get vaccinated, but the vaccine doesn't work amazingly well, it's only a partial protection, then they might still have replication going on inside their bodies. If their heart gets infected, what will that mean? Maybe they won't die within a week. So we won't see with the short-term vaccine trials that it's not we won't see them dying within a week, but maybe over the course of a few years, we'll see additional heart failure and other kinds of ramifications associated with that infection. And this is something we really need to be paying more attention to. The one other thing now I just want to talk about here is the death certificate. So what was unique about this, and so this was tweeted by the executive branch, and so which is astonishing that there'd be so much miscommunication, that the CDC would be saying one thing and that this would be tweeted by the executive branch, by the president, suggesting that only 6% of the death certificates were true COVID. The problem is, and here's what a death certificate looks like. So on a death certificate, the very first line is what the person actually died from, the most proximal, the closest thing. So if someone has a heart attack, or in this case, if they have respiratory arrest, then that's put on the first line. But the respiratory arrest could have been caused by pneumonia. So that would have been the second line, even though the very last thing that they died from was the respiratory arrest, that was brought on by the pneumonia. So pneumonia would be put on the second line. And then the pneumonia might have been caused by the COVID-19. So COVID-19 would have been put on the third line. So however people die, they should have multiple lines referencing what happened. And COVID-19 should be put somewhere on the death certificate. So there's a couple problems that we see. First, it seems if they're saying that 6% of death certificates only mention COVID-19, then that means on some of these death certificates, there are no other causes that are listed. It's just COVID-19. So that's very poor coding. Instead, people should have put what the other actual causes of death are in addition to the COVID-19. Did they have cardiac arrest? Did they have something else going on? We don't know, because all they put on the death certificate was COVID-19. So that's not great. But then typically you should have a lot of different things listed that were the whole sequelae that were associated with the disease, so that you can go back and do studies looking at this stuff. So basically, when it comes to looking at COVID-19, so based on what I just mentioned, there's a lot of death certificates that should have COVID-19, but maybe they only have respiratory arrest or pneumonia on it, but don't have COVID-19 when they really should have COVID-19. And similarly, there's a lot of COVID-19 where they don't have the full list of sequelae that are on that death certificate. And so ultimately, whenever we look at this, we have to always make this Punnett square to be able to compare what we're looking at. And so as of today, our best estimates are these two bold numbers. And they both come from different parts of the CDC's website. They're publicly available. Anyone can take a look and download them and investigate them. But the 188,000, this number are diagnosed, reported COVID-19 cases. So on their death certificates, it says COVID-19 somewhere. And the 250,000 are the excess deaths during the COVID-19 pandemic in the United States, so the epidemic in the United States. All right, any other questions on this so far? Hopefully this has elucidated this a little bit more.
No, well, the next question is, what will make a good COVID vaccine and how will we know?
All right, so let's go up here for a second. All right, so there's a bunch of things that I'm looking at in a vaccine when we're investigating it. The first three the first two should be what most people are thinking about: morbidity, mortality, or I should have also put safety in. It's not too late. I can type it in now. So on the fly, there you go. So the first thing are morbidity, mortality, and safety. Those are the big three that people are looking at. So morbidity is disease. Does it reduce symptoms? Does it reduce disease? Second is mortality. Does it reduce death? So for instance, if it reduces disease in most people, but it doesn't really reduce death, then that's really not going to be as beneficial as we would need it to be. Because, so for instance, one example of this could be maybe the vaccine works well in people under the age of 65, but doesn't work very well in people over the age of 65. So it could not be preventing mortality very much. It would still be beneficial for the people under age 65, but they tend to be at much, much lower risk. So it's not going to be as necessarily as good a vaccine. The other thing that we really need to worry about is safety. Safety I'll get to in a little while, but safety we've talked about. It's not, for this disease, safety is not really the site injection. That's really not what we're worrying about as much. I mean, there might be some stuff, but we're not going to be, that's not the primary focus. The primary focus here are these adverse dependent events that we're going to be talking about. We've talked about this previously. I'll get into it in a second. But there's another really important component of a vaccine that we really have to talk about, and that's this idea of spread. So one of the things we've been talking about with vaccines is that if a lot of people get vaccinated and it provides protective immunity, then that means that it could get us to the herd immunity threshold faster. So if 80% of the population gets vaccinated, then hopefully we'll reach herd immunity and we won't have to worry about the virus spreading anymore because we'll have herd immunity. The problem is you can make a vaccine that does reduce morbidity some, it does reduce mortality some, but people could still get sick, just not, they could still get infected, but just not have as many symptoms. They could but just have a more mild form of the disease. If they have a mild form of disease or asymptomatic, they could still be spreading it to other people. And the worry there is then that it does not provide any benefit for the herd immunity threshold. And even worse, if a lot of people, if millions of people get vaccinated, they might change their behavior and not wear masks as much, not physically distance as much. And so instead, you might actually increase the rate of spread among people who are vaccinated, which would not be something that's good. And right now, it's not clear to me if the clinical trials investigating vaccines are sufficiently investigating this. So when we look at the results, this is going to be something that a lot of us are looking at. Does it reduce spread? And because if it doesn't reduce spread, and once people get vaccinated, they're going to want to return to normal as soon as possible, which means getting rid of the masks and not physically distancing and going back out to the bars. And this could be problematic if it increases the rate of spread. The other thing is, as I mentioned a little just a minute or two ago, is that high-risk populations sometimes react to vaccines in different ways. So for instance, people with challenged immune systems frequently can't take vaccines, or the vaccines are not as effective in those challenged immune systems. And for this disease in particular, we know that people who have comorbidities are at higher risk, and people at higher age are at higher risk. And we know that some of these comorbidities, and in particular higher age, does challenge the immune response to a lot of vaccines. And so this is something else we're really going to have to be paying close attention to ensure that we are, that the vaccines are safe, effective, and useful for everyone who's at risk. So I'm going to go into a little bit more detail here. First, I'm going to jump, while we're on vaccine, before I go into some of the other details, I wanted to just mention one thing. So there's a lot of worry about these vaccines being launched too soon as an October surprise by the executive branch, just because there's an election coming. And one worry that people have is that sort of is confirming their fears is that the logistics, that the executive branch, the FDA, has signaled to states and to communities that they need to start getting ready for the logistics of the vaccine deployment, for the distribution. And for me, this doesn't concern me, actually. The distribution, the logistics, when you look here, this was the timeline that came from the New York Times, and this is a typical timeline of vaccine development that we're looking at. You can't forget this distribution phase. It's down here. It can easily take months to get to distribute a drug. And so if a good vaccine comes out that's legitimate, that passes all the tests, that's legitimate, then we need to reduce this distribution as much as possible as well. So I am totally comfortable that we are jumping to get the logistics in order for the distribution now, even with the assumption that it will be ready at some point. I'm comfortable with this just because, can you imagine if a vaccine gets approved and then we have to wait? Let's say it meets all the best criteria, everything that I just mentioned. It's reduces morbidity, reduces mortality, it's safe, it reduces spread, it's good for high-risk populations, but then we have to wait another 3 months while a third surge is happening across the United States. That would be terrible. So I think it's great news that we are doing this, that we are really focusing on logistics now. So I don't see this as a bad signal. I see it as, I'm not, this doesn't concern me so much. We should be putting effort and money into resources because it's a complex distribution that we're really gonna have to be dealing with here. Some of the vaccines have very complicated storage requirements in terms of they have to be held at like very, very cold temperatures and other things. So getting all the logistic stuff ironed out now, I think that's good news. That just makes good sense, I think. But let me jump back in. There are a few things to talk more about this that we're going to be looking at. One thing is there's a lot of different viral candidates that have made it this far. I mentioned earlier that at one point there were over 100 vaccine candidates. Now it's been reduced to 27 that are in clinical, that have made it to clinical evaluation, which is good. They're going through clinical trials, and now there's 139 vaccines in preclinical development. So they're being studied in animals and cells and other systems. Of the 27 vaccines undergoing clinical evaluation, there's 3 candidates that are in phase 3 trials that are really close, within months potentially, if we have good results, that they could be launched. And the 3 are the Pfizer vaccine, the Moderna vaccine, and I think AstraZeneca was the 3rd one. And these are the Pfizer and I believe AstraZeneca are both viral vectored, and then the Moderna one I think is the mRNA-based vaccine. So the safety. So I've talked about antibody-dependent enhancements before, and the worry here is that normally the SARS-CoV-2 binds with the ACE2 receptor. And so we've talked about the ACE2 receptor a lot. The worry is that there's an additional receptor, a backdoor, and that's the FC receptor. And the FC receptor is located on some immune cells, and in particular, it's located on macrophages. And so what that means is that in addition to being able to infect lung tissue and heart tissue and other systems, it can also infect macrophages. And when it infects macrophages, then it causes all sorts of problems. Because if you kill off the macrophages in the body, then that's where you have another trigger for a massive immune response and where it causes a cytokine storm and all these problems with the runaway immune system. And so this is something that we're looking at heavily. And so this is being evaluated. We know that in SARS-CoV-1, there was some evidence that this was an example where it was found. Dengue virus is a more traditional example that we look at in terms of looking at this. But so this is something that a lot of us are going to be paying close attention to when we read the results of the vaccine trials. Another thing we're going to be looking at is a T-cell response. We've talked about the T-cell response, that it's not only an antibody response we're looking at, it's also the T-cell response. And there's actually different kinds of T-cell responses. And so one of the things that we've noticed is that a Th1 cell response tends to provide a much better signal, much better immune response, protective immune response, than a Th2 response. And so we're going to be looking clinically to see among people who get the vaccine in these phase 3 clinical trials, are they getting more of a Th1 response or a Th2 response? Another thing we're looking at is where the T cells are located. So T cells that are located in the respiratory tract are way more effective at preventing lung symptoms and lung damage than T cells located in other areas. And so unfortunately, so there's different pathways that you can give a vaccine. So for instance, one vaccine that's in an earlier stage of development, it's not in phase 3 clinical trials yet, is, for instance, a nasal spray. And the nasal spray has the advantage of potentially increasing the amount of the immune response in the lung tissue. Whereas parenteral, which is an injection vaccine, tends not to have the same level of immune response in the lungs. So when we have the injection, then it's unclear. And again, based on what I was just mentioning a little bit earlier, that in addition to being a lung disease, we really need to think of this as a heart disease. COVID-19 is a heart disease, and it also impacts the cardiovascular system, the gastrointestinal system. We need to see how the immune response varies by system, not just if it's just an overall antibody response, and not just if it keeps people out of the hospital on the short term, but we really need to be investigating people's hearts who get the vaccine. Does it prevent heart attacks? Because they might be asymptomatic, but still be getting heart attacks. And I need to see that data because of the things I've just shown you previously, that this is a cause of concern for me, that I need to be looking at when the vaccines report out. But looking across the systems in general. So again, cardiovascular system, the gastrointestinal system, other systems, to see what the immune response is that's located there. And then the T-cell mediated immunity. So we talked about this, and this is particularly important for seniors apparently. So the antibody response fades. We're gonna have to see how long it lasts. For a lot of these vaccine trials, a person gets a first loading dose, and then they get the booster shot some months later. I don't know if that's sufficient. We might need to have a third booster shot or something within a period of time among people who are particularly at high risk. Additionally, in terms of rolling out, there's going to be people who are probably a priority in terms of the vaccination. These are healthcare workers who are on the front line, who are at the highest risk of being infected. Then there's individuals with comorbidities. So we do know that there's the higher risk comorbidities like diabetes and some of these other things we've discussed previously. People over the age of 65 are at a higher risk, so they'd have a priority for vaccination. And then ethnic minorities. So these would be the first, during the first, the earliest ones to get the vaccine. Later, we'd start to give it to a wider number of people as the vaccine became more available. And that would be people with who may have been exposed to SARS-CoV-2, people who might have previously gotten infected and might have waning immunity, so we need to sort of boost their immunity again, and then some other individuals. And then finally, we'd roll it out more nationally over years. This would be something where you'd be continuing to vaccinate people over years globally. In terms of this timeline, I cut this out over here, but you see the bottom here is where this fits on the timeline. So it should be that this is over here somewhere. But you see that in the short term, the priority, so there's not going to be enough vaccine. That's not necessarily a bad thing, but what it means is that we need to prioritize who gets the vaccine at first. Because like I said, a lot of us are expecting this third wave coming in the winter. Once we find that we are satisfied that the vaccine meets all of our requirements that I just described, that it really truly reduces morbidity and mortality, that it's truly safe, that it reduces spread and these kind of things, we're going to want to get it out there as quickly as possible for the highest risk people, and then ultimately to prevent spread for wider distribution and dissemination. All right, I think that was all I had to talk about there. Are there any questions on what I just talked about with vaccines? Nope. Okay, if there are, then just text.
I have one question.
Okay, go ahead.
What was that about the vaccine out of Russia? Was there any truth to that?
Oh, yes. So actually there was. So China actually was the first to release a vaccine, and they released it for their military only, I believe. But it didn't go through phase 3 clinical trials yet. And similarly in Russia, the difference is that Russia is releasing their vaccine to wider distribution, and there too, it has not gone through phase 3 clinical trials. So we don't know if it truly reduces morbidity. We don't know if it reduces mortality. We don't know if it's truly safe. We don't have any idea if it's reducing spread. We don't know the answers to any of these things. So it has passed phase 1 and phase 2 clinical trials. So we do know a little bit about it. To pass those clinical trials, we have to know that it does trigger an immune response that appears to be protective, that it at least seems to have met a basic safety threshold. But it probably for phase 1 and phase 2, you're not going to probably have looked at sufficient evaluation for high risk populations or for a lot of these other things. The worry in particular, so in addition to these worries, which are legitimate concerns, and the reason that we should not release a vaccine before it's completed phase 3 clinical trials in the United States, but the reason that it might not be as effective in addition to these things in Russia is because the specific vaccine that they approved is based on a vector. So it's based on a previous infection, and the previous infection that is something that's used sort of as the vehicle on which the new the SARS-CoV-2 antibodies would sort of develop from. And the vehicle that they used originally from this previous pathogen is actually a pathogen that exists somewhat widespread. And so a lot of people might already have antibodies to the vehicle itself rather than to the SARS-CoV-2 thing on the vehicle's hood that's supposed to trigger the new antibody response. So if the immune system is knocking out the vaccine before it even has a chance to trigger a new antibody response, then it's not going to be effective in those people. And so that's another worry, that it just reduces the likelihood that it's successful as a vaccine in inducing protective immunity for SARS-CoV-2.
I have a question also. Glenn?
Yes, I can hear you.
Okay. Are these going to be very expensive, these vaccines, and who's going to pay for them? And if that's the case, what happens to the poor sectors of our population? My other question is, if the first ones to get it are the most important or the most in danger, do you think we should try it out on first response people?
Yeah, so the first responders would be part of the healthcare workers that they're talking about here.
Would that be dangerous? We don't want
to. So right. So it would only, presumably, if it passes phase 3 clinical trials, then that would meet our thresholds that we're confident that it's both safe and effective. So that would be the only way we'd do mass vaccinations. But to your point about cost, so yes, so the vaccine should be free or near free for out of pocket for all people who receive it. What that means behind the scenes, I think is still maybe to be determined for a lot of people, whether it's the government that is paying that behind the scenes, or the pharmaceutical industry is reducing the price, or what that actually means behind the scenes. I'm not quite sure. I do know that the federal government in the United States invested billions of dollars for the pharmaceutical industry to invest in these drugs, to get them up and going. And so that reduced the risk a lot for the pharmaceutical industry, because they didn't have to risk the drug failing and then not getting the return on investment. And so because the government took on this risk, I fully expect that the cost is going to be extremely low on the pharmaceutical industry side, but it should be irrelevant. For the patient who receives the vaccine, I'm assuming it's going to be 100% free. It might be that the insurance company picks up the rest. It might be that the government funds it. I don't know, but for almost everyone, it should be very easily accessible, free, just someplace where you go to a local, I don't even know how they're going to distribute it, but it should be very easily accessible and without cost.
Okay, Harry has a question.
Okay.
So my question is, in the details that you've described, giving it to the healthcare workers first, but if the Trump administration promotes this vaccine before you actually have confirmation of true third degree or third level qualifications, aren't you risking the whole medical establishment by giving it to them first?
Well, so I suspect a lot of people would refuse to take it. In fact, there was a recent survey that suggested approximately 2/3 of the American public, because they're concerned about this October surprise, apparently around 2/3 of Americans would refuse to take a vaccine when it first comes out, which is worrisome because if it does pass our thresholds that I mentioned over here for truly reducing morbidity, mortality, it meets the safety threshold, reduces spread, etc. If there's vaccine hesitancy and people aren't getting vaccinated despite this, then that's worrisome. But this has the potential to be a real mess. If it is approved prior to the phase 3 clinical trials being done, or if the phase 3 clinical trials are done, but some of the concerns I just mentioned were not sufficiently addressed in those trials, then there's probably going to be people who are not going to be willing to take the vaccine. And that's a problem. This is something that's, yeah, I don't know. There's not a good way to, I don't know.
Okay, ready for the next question?
Yeah, the one thing I can just add is, so when we're talking about vaccines, also talking about the flu vaccine, which is a very different type of vaccine. We've been using the flu vaccine for many, many years now. We know that the flu vaccine is safe and effective. It's already gone through all of these extensive trials. Everyone should be getting a flu vaccine if you haven't already received it yet. The good news is, based on when we look at South America and the Southern Hemisphere, the flu has been extraordinarily low this year. Because people have been wearing masks and physically distancing and whatnot, we've seen an extraordinary, dramatic reduction in flu in the Southern Hemisphere. So we are fully expecting there's going to be, even without a flu vaccine, that there'd be a dramatic reduction in flu in the winter for us, which is great news. And in particular, it's because the flu shares so many symptoms with COVID-19, and it might take a while to get the results of a COVID-19 diagnostic test. Anyone who got the flu and would be presumed COVID-19 until you knew otherwise. And if you had both viruses spreading at the same time, it could be very problematic in terms of understanding what was going on, and it would really challenge our resources. But so for a couple of reasons, everyone, despite what I just said, we want to get the numbers, whatever the flu that's circulating is, we want to knock it down even further. So everyone should be getting the flu vaccine, and it'll keep us healthy. It'll prevent the having comorbid SARS-CoV-2 and flu at the same time. It'll really be much better for everyone if we try to eliminate flu as much as we can this season.
Okay. Okay. Can you?
A quick flu question. I'm so sorry, but one doctor said get it now, and one doctor said wait because there's no booster and you want it to last through the winter. What is your opinion on that?
Yeah, that's a good question. It could go either way. The problem is that the immune response to the flu vaccine doesn't last very long. And in particular, the older a person gets, the less long it lasts. And so therefore, a lot of times some physicians might say, well, you should wait a little bit later to avoid, or so that when February, March comes, you're still protected. Whereas other people say, no, get it earlier, because if you don't want to be at risk from the flu in September, October, November. I would suggest getting it sooner rather than waiting for people over the age of 65, and then potentially getting a second one in the spring if you need to. And because there's no harm in doing that, and why put yourself at risk now in September, October because of waiting for some reason? I think get it early and often.
Interesting. Thank you very much.
I'm an epidemiologist. I'm not a physician, so you really have to talk to your own physician about the vaccine schedule for this. But I know at a public health level, we are recommending that people get vaccinated now, that people get it early, and that we just start getting people vaccinated now.
Okay, thank you very much for that, Glenn. It's very helpful. Can you tell us about the Lamma antibodies? Are they a good candidate for a COVID-19 vaccine? And how about nasal sprays that you had mentioned earlier?
Yeah, so this is interesting. This is all extremely early in development. These are what I would call candidates. Lamma antibodies in particular, apparently they're unique. I hadn't really known anything about this before the question. And so apparently Lamma antibodies, what makes them unique is that they're really, really small. And so because they're much smaller than normal antibodies, they're apparently have the potential to be more protective or to act in different ways. And so they're being investigated for COVID-19, so for SARS-CoV-2. The problem is they're really, really early. I think that they're not even in clinical development. So I don't even think that they're in phase 1 clinical trials yet. It's really early. So it's not something that we're going to be looking at anytime soon. But who knows? If God forbid the frontline vaccines fail to give us the results that we want, then maybe these other vaccine candidates that are coming through might be another wave of potential success. So maybe we don't have the vaccines by December, January, but maybe by June, July of next year, we do have the vaccines, depending, because there's all these candidates that are still coming through the pipeline, which is great news. So we don't have to rely too much on any one candidate. There's still over 100 candidates that are out there. Another one here is that we're looking at is the nasal spray vaccine. But this is, again, the same issue. It's not in phase 3 clinical trials yet. So it's further down the pipeline that we'd still have to wait to make sure it goes through all the clinical trials to ensure that it meets all the things we just talked about with safety and efficacy and all that.
Okay, thank you very much, Glenn. Okay, some major figures in public health have come out against the CDC, even concluding that we should ignore the CDC. Should we ignore the CDC?
Yeah, this is an interesting question. So the CDC is a massive organization. It does a lot of great work. The data that we talked about earlier, it collects and reports a lot of that data. It does a lot of great work. The problem is the leadership of the CDC is a political appointees, and that's problematic. In particular, one of the most recent things that they've said is that there should be less testing of COVID-19. And that is exactly the wrong thing that we should be saying. So from a public health perspective, the CDC has failed. Or so from an epidemiology perspective, the CDC is failing here because the guidance they provided is not sufficient. And so a bunch of really big figures have come out. A lot of epidemiologists I know are now saying that local public health communities at the state and local level should be ignoring the CDC. And this is astonishing. The CDC used to be the best in the world. It was the front line, the flagship CDC of all countries in the world in dealing with pandemics. And the fact that now key epidemiologists across the country are saying to ignore the CDC is astonishing. In fact, including previous heads of the CDC. And so in particular, give me 1 sec. In particular, when you compare, let me go back to what we were looking at earlier. I'm going to just compare the European Union to us. Well, although in Asia and Africa, not Africa, but Asia in particular, when you compare the shape of our curve in the United States with Europe, with European Union and Asia, they got their numbers down to a low number based on that they quarantined. They shut down for long enough, whereas we didn't shut everything down. And that's the reason we never got our numbers down low. But they kept their numbers low because they were testing and tracing way more than we were. And in particular, Asia doing a ton of testing and tracing in China and some other places. And as a result, that is the whole reason why the United States has this massive number of cases and we have the acute deaths that we saw, but then also the potential long-term problems that we're talking about, where people who recover, a lot of people have this long-term sickness now that they haven't fully recovered from because it's infected their heart and it's infected their cardiovascular system and whatnot. So when you compare ourselves, not testing enough is what got us into this problem in the first place. So the fact that the CDC is saying don't test as much, well, guess what? Maybe that's explaining why we're flattening over here and not getting our numbers back down to where they should be as we go into the fall and winter season. Every epidemiologist knows that these non-pharmaceutical interventions, this testing and tracing, that the standard stuff that we've known for hundreds of years, this stuff works. You don't need an effective therapy if you test and trace enough and can prevent the infections from starting in the first place. And so it's come to that. I agree. If people who are seeking to promote the public's health should not be looking to the CDC as the front line of information for guidance on this. We need to be testing more rather than less. And it's simple.
Okay, we're coming towards the end of your session, so I'm going to ask one more question and then maybe you can tell us some good news. Have we seen a spike in pregnancy rates around the world? Should we expect an influx of newborns around December?
That is a really good question. So there's two ways to answer this. There's a bunch of studies actually that have looked at this, so I'll jump into them. But so we won't know for sure how many new births there are around the world until December or so 9 months after March. But you would expect to see an increased rate, if there were more pregnancies, an increased rate of OBGYN visits, and further, you'd see sort of this early signal of increased pregnancies before then. And so that's still being investigated. I haven't seen anything that's been published in particular on that. Excuse me. But there have been some studies looking at what we expect in different parts of the world, depending on what's available. And so, for instance, in high-income countries, work-life balance has gone down actually over COVID-19, which would probably prevent fertility, so prevent increased reproduction. Economic losses and uncertainty has gone up, and access to reproductive therapies, assisted reproductive technology has gone down. So because of that, we expect in high-income countries, the fertility rate actually will go down, and that the population size will go down as a result. So we're expecting less pregnancies. In other countries, there might not be access to contraception. And so, for instance, in low-income countries, you might see a bigger spike during the shutdown than you would have in other places. And so as a result, you might see an increase. So we expect to see an increase in some. In some middle transition countries, where you might, in urban areas, there might be a difference versus the more rural areas, depending on the economic losses and access to contraception, those two might compete with each other, and that might decide fertility. So it's interesting, when you look in the United States, there have been a bunch of surveys that were published. There's one organization in particular, the Guttmacher organization, the Guttmacher Institute, and they were investigating this, and they've asked a bunch of questions. So in particular, whether their responses have shifted based on the COVID-19 pandemic to whether they want more or less children. And you can see that as many as half of Hispanics and almost as many as half of Blacks say that yes, it has shifted a lot. So 28% of whites in the US say that it's shifted as well. So a lot of people have demonstrated that it's shifted. Among people who are poorer, they tend to have shifted even a little bit more than people who are not as poor, which is interesting. Many people have indicated that they are having trouble obtaining contraceptives. And so 38% of Hispanics have said that they're having trouble obtaining contraceptives. And so if they are less likely to get contraceptives, then that might increase the fertility rate. And so overall, around a little bit more than a quarter of Americans have said that they're having trouble getting contraceptives, affording contraceptives because they're out of work and whatnot. So you might have unexpected pregnancies, not because that they're wanted per se, but because of the lack of contraceptives. Interestingly, when you compare the COVID-19 epidemic to the 2008 recession, which also had financial risks and things like that, but didn't have the same shutdown where we had to lock down indoors, there's a lot of similarities. In both cases, people tended to want to have kids later than they previously planned, or they decided to have fewer children than they originally planned. With COVID-19, they're reporting that they're being even more careful about contraceptive use now. And they're also reporting a lot more that there are the SRH's, sexual and reproductive health, that they have canceled or delayed their sexual reproductive health appointments and contraceptive care. So it's interesting. We don't know for sure yet. There were a couple things that are fascinating. I wasn't even aware of this. I should have been paying closer attention. But the US federal government apparently asked the Supreme Court to reinstate medication abortion requirements despite COVID-19. And so essentially what they're asking the Supreme Court to do is, because of COVID-19, a lot of people couldn't go to the physician's offices, particularly during the shutdown. But even without the shutdown, people were afraid of going into a healthcare setting and potentially getting infected with COVID-19, particularly if they're pregnant. They don't want to expose themselves in that situation. But among the pregnant women, even ones who are seeking an abortion, particularly because of COVID-19, the things we just discussed, where maybe they don't have the financial security, they lost their job. You would think people might want abortions because of this. They don't want an extra kid. So the federal government was allowing people to get abortion prescriptions through telemedicine, where they would just have a conversation the way that we're having a conversation here with their OBGYN or their physician, and they would go through the whole procedures that they would normally go through. And then if they decided that it was the best course of action to get the abortion drug, then just having the conversation with telemedicine would be sufficient. And they could go to the pharmacy and get the prescription filled. But the US federal government, the executive branch, has now gone to the Supreme Court to make it illegal to do that and to prevent it. So people cannot have telemedicine to get an abortion and get the prescription for the abortion. And so I don't know where this stands now. This article was as of the end of August. So I think it's still working its way through the Supreme Court, but this is worrisome. I mean, if people don't have reproductive freedom during COVID-19, it's very worrisome. The other thing is there's been a bunch of states, I was also unaware of this, a bunch of states that have put in policies to make it harder to get abortions during this time. And I think this is related to what we just said, the last slide I just showed. Abortions are currently permitted everywhere, but the fact that these green states have actually started to develop these policies, even if they're not fully implemented, is, to me, it's just astonishing. So I don't know what this means in terms of what the number of pregnancies will be, but just this idea of sexual and reproductive health at risk during this epidemic is sort of another fight that's going on at the same time, which is a little bit disconcerting from a public health perspective. But yeah, that's all I know for now.
Okay, well, I think this was another wonderful session, and we thank you very, very much for all of your expertise. Is there any good news that you'd like to share with us before we end tonight?
Good news. Well, it's been great seeing everyone. I mean, it is good news that the numbers are no longer at the peaks that we saw a couple of months ago in July. And, it's still, everyone, I hope you're having a good long good long weekend in the United States, the end of summer, Labor Day weekend. And so I hope that everyone's enjoying it. And so that's good news. You take it one day at a time. Take the good news where you can get it.
Okay.
So everyone have a great week.
Thank you so much, Glenn. See you next week. Okay.
Sounds great. Thanks, everyone. Bye-bye.
Thank you. Bye-bye.